Good morning and welcome to Breakfast with the Chiefs. Hopefully everybody had a good summer. We have a packed house this morning, so if you have a seat beside you, please feel free to put up your hand so people will know where some extra seats are, because we're going to be looking desperately for them. For those of you I have not met before, I am Matthew Hart with Longwoods Publishing, and we are about to enjoy our, it's not our 15th season of Breakfast with the Chiefs, it is our 15th plus season of Breakfast with the Chiefs. We have been joined by some of the most interesting speakers and some of the most interesting audiences that we have had in healthcare, so congratulations to you. Before we start, these events are not possible without the support of our sponsors. They are what make these events possible. So I would like to thank the Canadian Foundation for Healthcare Improvement for supporting this morning, HEROC for this morning, and as well, I think Aaron Burke from KPMG is in the audience. Aaron, feel free to put, there it is. And KPMG has also made this morning possible. Again, this facility is provided by Rotman, and to introduce our speaker, I would like to ask Brian Golden to come to the stage. Thank you, Brian.
Good morning, everyone. So just like a typical class, there are empty seats in the front if you're sitting on the floor in the back. I'm going to welcome you to the school. These have been exciting times at the Rotman School in the last few weeks, especially in healthcare and life sciences. And last week, we launched our new Global Executive MBA in Healthcare and Life Sciences, and I just want to take 30 seconds to talk about that so you can spread the word. This is it's a program that is designed for working professionals who are clinicians, engineers, government, from payers, from the public sector and the private sector. And it will be a full MBA. This has been something I've been dreaming about bringing to the Rotman School for 15 years. The focus is on the full value chain. You know, it's about breaking down the silos, very consistent with the theme today. And unlike a few other schools in this space, all of which are south of the border and focused on the U.S. model of care, our focus will be on global best practices in healthcare and life sciences. And that's what we try to do in all of our work at the Rotman School. We will be in Toronto, we'll be in the San Francisco Bay Area, and we will be in Singapore. So grab a postcard on your way out, spread the word. I look around, not too many of you are too old to be thinking about a program like this. You're never too old to be thinking of a program like this. But spread the word. We're really excited, and it's our chance here in Canada to make another impact on how the world organizes healthcare and life sciences. So enough of that. I'm really pleased to introduce our friend Susan Fitzpatrick. Susan was appointed Chief Executive of the Toronto Central Local Health Integration LHIN in 2015, following a career in the Ontario Public Service. Prior to joining the LHIN, Susan was the Associate Deputy Minister of Health System Delivery and Implementation at the Ministry. As Associate Deputy Minister, Susan was responsible for bringing together health programs in the LHINs, CCACs, long-term care, and physician services. I don't think there's anything she wasn't working on in her career at the Ministry. And most importantly, creating alignment in order to deliver exceptional care. On a personal note, I was actually quite sad when I heard the news that Susan was leaving the Ministry. We had been working with a group of colleagues on primary care strategy for about 3 years when Susan announced her departure. But thankfully, it was then announced that she was going to be coming to the TC LHIN, where she was going to be able to lead all of the work we had been talking about for so many years. So it's with great pleasure that I introduce Susan Fitzpatrick.
Thanks very much for joining the session today. It seems a little bit strange to actually be presenting rather than attending, but I'm I'm looking forward to sharing with you some of the ideas I've developed over the last 2 years while I've been at the LHIN. And as Brian said, I think I had 30 years leading up to the job at the LHIN. I think we're really well poised to make a significant difference. So I want to talk to you about what I think the role of the LHIN is in moving forward the implementation of integrated health delivery systems. The province has put in an enabling framework of legislation, regulation, policy, and funding that will allow the LHINs to have a meaningful role in creating a more fully integrated system. And after all, that was the original reason for creating the LHINs. The Minister of Health and Long-Term Care has recognized the LHIN role in our mandate letter, which I've presented on this slide. And there is no single solution or path forward. I'll be speaking about how I think integrated delivery systems can be created in an urban center. Other LHINs will identify their own approaches. With Lycia, Patients First, and the mandate letter from the Minister, our task is clear, and we are going to create integrated service delivery networks that include the full continuum of care. I wanted to share with you a quote from Stephen Shortall. So when I was getting ready for this presentation, I reviewed some of the literature, and I think this quote really reflects where we're at today. The largest limiting factor is not lack of money or technology or information or people, but rather the lack of an organizing principle that can link money, people, technologies, and ideas into a system that delivers more cost-effective care than the current arrangements. So I'd like to suggest to you that the LHIN is the organizing principle. We will organize systems of integrated care along sub-region populations. This is largely about organization and creating new and stronger integrated networks. Why a whole system approach? This is a slide I used in many of my presentations at the Toronto Central LHIN. When I joined there, it was very puzzling. We have over 226 health service providers with 226 plus accountability and funding agreements in 6 separate and distinct sectors, and another 1,300 healthcare providers managed by the ministry. This is only one of 14 LHINs. It's no wonder that the coordination of services is complicated and navigation is almost impossible for our citizens. And we hear that over and over again at our sessions with citizens in the Toronto area. The result? A fragmented experience for many individuals, families, caregivers, and providers. The individual's experience is fragmented for everyone, and most significantly for those with greatest complexity, and for both individuals and providers. And even when sectors want to connect, there are barriers that make it difficult. And we've put the little pylons in the chart to show you that even if you're trying to connect with another sector, there's usually a block in your way. Oftentimes, providers are not aware of who is working just down the street or who their common clients and patients are. We see this all the time when we bring people together and they're meeting colleagues for the first time. And it's especially frustrating for individuals that require multiple providers. And I would suggest to you that we should not be designing a system around budget centers, nor should funding flow be so tightly restrained between sectors. Everyone realizes that we can do a better job. So what did our citizens tell us? Last year alone, we engaged over 600 health service providers, patients, caregivers, and residents through over 20 face-to-face consultations, as well as through surveying. And we captured, in essence, what they told us. I don't care how you organize my health care or about the rules. I just want care when I need it, where I can get to it, and to feel confident that it is going to make me better. They told us over and over again that they need better access to care so they can stay at home and be healthy. They need help with navigation and coordination. It's stressful doing it on your own. And they view us as one health system, and they expect us to act as one team. These priorities, access, navigation, coordination, and communication, are the underpinning of all our planning at the Toronto Central LHIN. Secondly, our performance isn't where it could be. Looking locally, I've identified 3 Ministry LHIN accountability indicators that I think best reflect how well the health system is performing as a system, and we have trouble meeting these targets. I don't know if I should be presenting this with my board chair here, but we are working hard. ALC, alternate level of care performance. We are not meeting this target, and it tells us that we are not always serving people in the best setting as people wait for housing, home care, and long-term care. Repeat ED visits for mental health conditions tells us that care may not be appropriately joined up between care settings. And readmissions within 30 days for selected chronic diseases. Variation across the system tells us that service providers are not necessarily sharing best practices. Internationally, we are not a leader. In fact, we're in 9th place out of 11. We can do better in areas of access, equity, healthcare outcomes. And it's interesting that the same report also tells us that as a country, we continue to be high spenders relative to our performance scores. We have a lot to learn, and there's countries that have the best results, even though they have different funding models. So it's not all about the funding model. We can learn from UK, Australia, and the Netherlands. So how might we begin to design an integrated health system for citizens? We have a legacy system that was structured sector by sector. What would we do if we could design it from the beginning? So we might begin by shifting the current state from individual providers accountable to the LHIN, focused on elements or units of care, for individuals that are seeking health care, and separate systems of care influencing social determinants of health, to a future state with teams of providers or networks of care accountable to the LHIN, a continuum of health care including prevention and wellness, a focus on all individuals within the LHIN with the equity at the center, and I'll be speaking a bit more about that. And finally, better alignment between health and social services. What is different now? I want to spend a bit of time looking at why the current environment provides an opportunity for change that is new. I'm going to suggest that we are in a period of unprecedented transformation. I would be interested to hear any challenges to that statement. The reason I say this is I think we're poised to make a real difference. We have a clearly articulated provincial transformation agenda to guide the way supported by legislation. We are creating sub-regions designed to focus on local need and improve health equity. We have a new role as LHINs as a service provider. It changes our lens on the system. And it may mean that we're moving closer to the regional health authority model, and I say that with a question mark. Our agenda, we have one agenda and a greater opportunity to align our efforts. So I'm going to take you through 4 areas of opportunity. Service integration and alignment. We are encouraging integration along a continuum, from ad hoc linkages and coordination to structured collaborations. And I can give you excellent examples of structured collaboration. In Toronto, we have a Toronto Ride program through a collaborative agreement. We have integrated services for transgendered community, integrated services for schizophrenia, stroke care integrated funding model. Lots of examples. We know how to do it. To program and service transfers, we don't all have to be providing the same services. There's opportunity to rationalize, and examples of previous rationalizations have been transfer of cataract volumes to Kensington Eye Institute, consolidation of colonoscopy services, and transfer of vented patients. To full integration, full organizational integration. Last year, we had 8 full integration from all sectors and ranging in size from small to large, CHCs, community mental health, community sports services, LTC, hospital, and even a Ministry of Community and Youth Services community organization integrated with a hospital partner. So the system itself is seeking opportunities to more tightly integrate their services. I'm going to move on to local health and social partnerships, and I want to focus on 2 examples. One is an innovative discussion with the City of Toronto, and we'll be seeing them later today. So with the City of Toronto, we're working on a formal collaboration to work on mutual priority areas. And those areas that we've identified are primary care, long-term care, and seniors housing. In all 3 of these areas, there'll be a strong focus on planning for the future. I also wanted to call out our innovative community hub model, the Thorncliffe Park Community Hub, which includes community partners, the United Way, City of Toronto, LHIN and primary care, with health as an anchored tenant. Moving on to primary care clinical leadership, I think the key here is strong primary care, and I'm very proud to say in the TC LHIN we have excellent leadership. Previously, Dr. Phil Ellison was our LHIN lead, now Dr. Jocelyn Charles. We have 5 sub-region leads in place, and they've come together on a focused agenda. They are looking at improving patient access, improving service integration, and to increase service efficiency. We have 5 work plan priorities. Those were established about a year ago. We're working on attachment, access and continuity, access to interprofessional teams, access to specialist consultations, discharge planning, and secure communications. And finally, innovative home and community care delivery. We are creating community-based networks of care responsible for access, coordination, and navigation. We have home and community care directors in place in each of our sub-regions, and they are working closely with primary care. Principles of simple, accessible entry points, single assessment, one-step referral to services, navigation support, and care coordination are at the heart of this work, with a LHIN-wide infrastructure to support. Many of our partners are already advancing locally integrated and team-based care as naturally occurring integrated health delivery systems and are in the early stages of development. And there is opportunity for even greater alignment. As a LHIN, our opportunity is to build on this momentum and accelerate change. So what is the role of the LHIN? We have the experience, the people, the authority, and the relationships to integrate the healthcare system. We have the keys to unlock the system potential, remove barriers, and move towards greater integration. And I think this is really a pivotal point in my presentation, that the keys are with the LHIN. We have the enabling infrastructure and framework around us to do this work. The 3 key roles I'll be talking about for the rest of the presentation are creating a strong foundation, one common vision, a single plan with a path forward that is evidence-based, aligns with government direction, and responds to what citizens need. Secondly, bringing partners to the table. Understand and translate what our citizens need. Bring all of our partners together to plan with citizens and communities. In Toronto Central LHIN, we call this local collaboratives, and we have one for each sub-region. And finally, enabling transformation. The LHIN must fully employ our legislative levers, funding, integrating, managing performance, and providing high-quality home care services. We're going to take a closer look then at the three roles, starting with creating a strong foundation. We began by grounding our approach in evidence and in our citizens' voice. We created an evidence-informed design and implementation framework. And I'm going to talk to you about 5 different areas. What we know are characteristics for successful health systems integration. And I draw on the work of Sutter et al. On attributes for a high-performing system. They identify 10 areas, and I think they'll be familiar to all of you. Comprehensive services, patient focus, geographic coverage, standardized care, performance management, information systems, leadership, physician integration, governance structure, and financial management. Moving on, what do we know about creating a foundation for primary care? Well, we know a lot. We've done work. John Lavis at McMaster has held sessions. We at the Toronto Central LHIN with our primary care group are looking at the Bodenheimer model, 10 building blocks of high-performing primary care. And it brings in Barbara Starfield's foundational elements of engaged leadership, data-driven improvement, empanelment, and team-based care. And we're moving to a future state of a patient-centered health home. So we know a lot about that. What do we know about a practical approach to population health? We know that we should start by locating hot spots of the worst health outcomes. I'm going to talk to you about the work we've done on that in that area. Moving to locating at-risk populations, a further stratification, to looking at the full population, full stratification of the population with goals that focus on illness prevention and wellness. What do we know about delivery of home and community care? We can look at regional health authority models, Canadian models, and internationally. And what can we draw on through our decade of experience that tells us about how to create shared accountability? And most importantly, what we know is important from our citizens. Our citizens panel has worked with us closely through over the last year and a half to advise us along the way. And I also wanted to call out work that the Open Labs has done for us. They've created the local, a hyper-local storytelling medium where we can hear directly from our citizens. And their tagline is no data without stories and no stories without data. So through our collaboration efforts, we created a shared vision that will ground our quality improvement. So at the sub-region level, collectively, our mission is to change and strengthen the way we work together to meet the needs of residents of our local community. Our vision is creating healthier communities together. So you can see the focus on the local community. So what is an integrated delivery system? It could be viewed as a network of organization that operated as an integrated system to provide a coordinated continuum of care to a defined population and are held accountable for defined outcomes. The LHIN has developed a model adapted from the work of many. I've mentioned John Lavis's work, but we've got Baker and Axel, McClellan, our citizens panel. We've reviewed all that work. We've adapted our own framework. We are focusing on 7 areas The areas that I'll be speaking to you a bit more about are population health, outcomes, quality improvement, access, coordinated care, communications, and aligned incentives, all on a foundation of citizen voice, evidence, and patients first. While we have activity underway within each of these components, each component builds on the one before it, meaning that everything is rooted in our Toronto Central LHIN strategic plan. So firstly, population health. Shifting from a focus on individuals accessing the healthcare system to the needs of a full population. So on the left hand of the slide, we have one LHIN responsible for 1.3 million citizens. We have 5 sub-regions with approximate responsibility for 250,000 residents. And then we have 74 neighborhoods, and the average population of a neighborhood might be about 15,000. So you can see how we're progressing through to smaller increments for planning. And as we drill down on the neighborhood, we can get into what we call hyper-local planning. In 2016, we began our work with our partners to drill down to the neighborhood levels. We developed comprehensive sub-region profiles, and there's an example on the right side of the chart that included population demographics and distribution, as well as health outcomes and healthcare utilization at the neighborhood level, where we could begin to further stratify and analyze variations in health outcomes and utilization. Out of 74, we picked 5 hot spot neighborhoods. And I'll just quickly run through them just so you can see naturally reviewing the data, areas identified different areas for focus. One area of focus is chronic disease in Rockcliffe Smythe. Another is low urgency ED use and primary care attachment in Kensington, Chinatown. Thirdly, seniors living alone in Mount Pleasant West. And finally, mental health and addictions in Moss Park and Oak Ridge. And with Moss Park, the focus will be on the homeless. This is really the power of planning locally. Secondly, a focus on outcomes, shifting from monitoring and managing service utilization to health outcomes and experiences that matter to people. Population data begins to enable us to understand the needs of different population groups within the LHIN. In order to improve health, we must be able to monitor outcomes for every population so we can continuously improve over time. Some examples of clinical excellence are monitoring clinical outcomes for care pathways such as stroke care, our commitment to engage citizens, patients, and communities, and our new evolving relationship with public health to work together on critical overlapping areas such as the opioid crisis. Thirdly, shifting from individual performance objectives to local teams focused on quality improvement. We know that one of the attributes of high-performing systems is a commitment to building quality improvement capacity, and we're doing that at the Toronto Central. Our providers have been building QI capacity for several years, and the majority submit quality improvement plans to Health Quality Ontario. With our planned shift to locally integrated care, we're investing in building local quality improvement capacity at the sub-region level. Each sub-region local collaborative has worked together to identify a first quality improvement opportunity. The teams have been struck, and we are investing in QI training with the IDEAS program that will contribute to improved outcomes in those neighborhoods. Over time, we want to build towards larger common quality improvement plans at the sub-region level. Access. Shifting from individual points, access points facilitated through information and referral, to local networks of primary and community care with timely access to specialists. At the same time as we are understanding population and local needs, integrated systems must also simultaneously align the cornerstones of the healthcare system that our 1.3 million people need or will need to access. These cornerstones are ensuring that high-quality primary and community care is located close to home and close to home, and ensuring that specialist care is easily accessible when people need it, and that there is a seamless transition back and forth. Through initiatives such as primary care access to specialists, centralized intake and assessment, access to imaging, and coordinated access to mental health and addictions, we're starting to make improvements in access. Coordinated care. We're shifting from care coordination within sectors of care to the LHIN as a service provider of home care to a coordinated system of care. We're developing coordinated care plans that are connected to social determinants of health through high needs individuals. Through health-linked partnerships, we have made great progress in coordinating care for people with complex care needs. In a system with multiple providers, care coordination strategies are critical to ensuring that individuals with multiple care needs are receiving care that is coordinated and aligned to their goals. Our next progression toward a more coordinated system is to develop a model of needs-based care coordination that is a system resource for patients and family and includes connections to social determinants of health. And I would say this is a very, very important and necessary step that we need to undertake and undertake it quite quickly. So communications, shifting from communication that is largely based on relationships to secure, timely, and real-time information sharing. I couldn't give a presentation without saying something about the information technology challenges, although I think the digital health strategy is really starting to put the necessary framework and infrastructure in place. So we need comprehensive information structures as a core feature within the high-performing system that will enable information sharing, shared care planning, clinical reminders, outcome and performance monitoring, and in some cases even real-time patient engagement. Examples that we are undertaking in the Toronto Central LHIN are improving discharge planning reports from hospitals to primary care. I think we're almost at 100% compliance on the hospital report manager implementation. Providing all providers, including primary care, with secure email, doing a lot of work on that, and leveraging our home care infrastructure to become a common care planning tool. Finally, aligned incentives, shifting from incentives for activities and volume to incentives that support team-based care. Our healthcare system was based on a fee-for-service program-based model of care delivery, which was reflected in the way we fund care. So the first progressive step was quality-based procedures and integrated bundled payments structured for defined care pathways. Moving forward, I'd propose we need to reward networks of providers to become accountable for a population, and that will require us to develop a funding model for a prospectively defined population over a period of time and for an agreed cost. The second role of the LHIN is bringing partners to the table. How are we moving this ambitious transformation agenda forward? At the local level, we have created local collaboratives and primary care networks, which call on our partners to deepen their understanding of communities, align and integrate services to meet local need, engage in quality improvement, and build partnerships that advance social determinants of health. We are investing in staffing leadership with newly recruited LHIN leads for each of our sub-regions, who will work closely with home and community care leads, primary care leads, and other local leadership. At the system level, we have called on our partners to help us design a system of access, coordination, and communication for primary care, community-based care, and specialized care. And in our new role as a service provider, we are enhancing our understanding of how the system operates and creating opportunities for greater synergy. And finally, the third key is enabling transformation through our mandate to fund, integrate, performance manage, and provide high-quality care. So what will an integrated health care delivery system look like in the future? One, needs-based funding allocation for population at the sub-region level. One, locally integrated service delivery network at the sub-region level. One, collaborative quality improvement plan. One, publicly reported and person-centered scorecard with one outcome-based shared accountability agreement. And one, simple and coordinated access system for care. So this is what we're building towards. And this is what the system will look like at a mature state. And that means we'll have to change the way we do our work. We're going to have to change how we allocate funding to match population need. We have to facilitate partnerships and collaborations to move towards integrated networks. We have to submit collaborative QIPs to HQO. We must report on health outcomes and experience at the sub-region level. We must manage a single accountability agreement within each sub-region. And we must provide one simple and coordinated access system for care that will include one number to call. So how are we doing? Our assessment to date on our maturity model suggests that we've made some progress, but there's a lot of work to do. So we've shaded in the green where we think we've fully achieved, in the lighter yellow where we're making significant progress, and in the blue where we have a lot of work to do. I think it's all achievable. When I'm often out talking to our health service providers, they ask me how long this is going to take to do, and I'm going to say 2 years. That is the length of my contract with the LHIN, and I'm not leaving before I achieve it. So thank you very much. I'd be happy to take questions.
Thank you, Susan. So we have some time for some Q&A. I have a mic, and Rebecca over there also has a mic. So if you have a question, please raise your hand, and we'll hopefully get to as many questions as we can.
Hi, that was a great presentation. Thank you. Erin Tilley with the College of Nurses. So you talked about the citizen voice as a foundation, and I wondered if you could speak a little bit more about your strategy to engage them and to get meaningful input to support that foundation.
Yeah, I think it's been one of the more challenging things we've taken on. When I first joined the LHIN, I wanted to get a citizens panel, and we interviewed and struck a panel with about 19 citizens. And I have a few learnings from that experience. One is it's quite unique when you bring 19 people together that have no relationship, never worked together, have different perspectives of the healthcare system. So there's a lot of work necessary to work with the citizens, to form them into the group, to give them the right tools. And their feedback to us, they've talked about a type of accreditation, but a process that will really make them effective citizens in terms of their panel work. We're refreshing that now in response to the ministry's direction for patient and family councils. And we're going to use our experience over the last year and a half to keep making that effective. We engaged the citizens a lot at our sub-region sessions, so pretty well every session there were 2 or 3 citizens available. They participated in the discussion and gave a lot of really good advice. And I've also talked about the local, which really at our collaboration sessions, when we can see films and stories about individuals, it's really helped bring the kind of the focus down to the people that we're designing the care for.
Hi, Susan.
Hi.
Thanks for the presentation today. You talked a lot about the sub-region and how you're working within the LHIN. Can you maybe talk to us about how you're working across LHINs? Because people obviously don't just reside in that spot. They go for care. They work in other places. So can you talk a little bit about that collaboration?
Yeah, I think that's always a question I get when I'm out and about on the Toronto Central LHIN. I think, at this point we're trying to figure out locally how we're engaging our providers, but always recognizing that we have borders and we're going to have to start sharing practices across borders. So it's definitely something we have to do, and thank you for reminding me of that. Sometimes we get very focused on the individual LHIN, but we will need strategies to go well beyond that.
Hi, Susan. It's Marnie from
Hi,
UHN. Hi. Susan, you're not really the same as the other 14 LHINs, or the 13 LHINs, because part of Toronto LHIN role is around teaching and education and research and discovery and trying something and maybe it doesn't work. How is your vision going to help support that whole element that's so concentrated in your LHIN?
Yeah, I think my view is that the LHIN has a dual role. So a lot of this work is being tried to create integrated structures that will support the local community. But as you say, we also have a role that supports residents from around the GTA and across the whole province. So it is another role for this LHIN. So it is separate work that we need to do. I've spoken to Hospital for Sick Children, I've spoken to CAMH, and it may be that we're going to embed some leadership in mental health, in pediatrics within our sub-region model.
Me again. So 2 questions if I can. Everyone in this room is an optimist. We have to be. But there are some cynics out there who will say we've been doing this for about 10 years now. So what gives you the optimism? Why do you believe today in 2017 is different than 2006? And the second question, if you got a magic wand and you could do one thing immediately today to accelerate all of these changes, what would you do?
Well, I think, firstly, I talked about naturally occurring integrated health delivery system. The Toronto Central LHIN is not in the lead on that. There's other areas of the province that are much closer. There's excellent work being done in Hamilton, Muskoka, Barrie. So I think it's facilitating that. I think the biggest learning I've had over the last year is, I'm going to say, is relationships. When we brought people into the local collaboratives, we started introducing health service providers to each other that had never met before. I think we have a very, very good relationship across the whole sector. I would say in each of the sub-regions, people know who their colleagues are. They've started through the collaborations to contact people and talk about common issues in patients. So that's given an excellent foundation. I think there's 2 sub-regions in the LHIN that would be very amenable to trying to develop a construct for an integrated service, health service delivery network. And I think the LHIN role will really be facilitating that, bringing people together, getting the support, talking to people about what that will look like and what they will need. So what was the second part, if I had a magic wand? I'm not sure what I would do with a magic wand. I think, part of my hypothesis is that we have all the tools we need. So I guess if I had a magic wand, I would be looking at the skilled resources to support the evolution of a new system, and I will actually lead into kind of calling out my group. This isn't just my work, but Tess Romaine, my VP Strategy, Stephanie Lockhart, my Director of Strategy, our communications team, Megan Primo and Liz Leal, who helped me bring the presentation together. So it's really having the right people in place to try to advance, and working with academic institutions, really looking at the evidence and implementing it.
I, for one, am definitely one of the optimists in the room. So thank you. It was really exciting to see what you're doing. I'm actually originally from Ontario. I don't live here currently. And Shanti Gidwani from Cisco Systems. It was great to hear about the digital transformation piece as well. But my question is actually more around what you were talking about with physicians and fee-for-service. So I come from a family where both my parents were specialists. My brother's a GP here in Toronto. I'm a registered nurse. I was wondering if you can elaborate a little bit more on how we potentially make that shift away from fee-for-service, understanding what challenges that may cause within the clinician population.
I was pretty sure I was going to get that question, and I actually do not feel that there needs to be a change to, I'll start off with the physician compensation model. What we've been doing in this LHIN is looking at team-based care. So that's what we're trying to build out. And I think the Thorncliffe Park is an excellent example where physicians are actively involved, CHC physicians, but also faux physician groups. So it's not changing the basic payment to the physician, but it's changing their relationship with the system. And I think that's where we have to have, interesting discussions. We put in 2 interprofessional teams, one in the East and one in the West. And we said to solo practitioners, you can access those team resources. It's early days. And one of our projects was access to mental health specialists. And I think, about 300 or 400 physicians said that's what they would really want. So I think it's really working with the physicians so they become part of a network team as opposed to worrying about the payment model. Now, you've said you're a nurse, and I do want to kind of recognize in our new role for home and community, we have a huge clinical staff and, excellent nursing background. So that is a little bit about, shifting the lens for the LHIN to say we now actually have direct responsibility with nurses with clinical backgrounds that will take a larger role.
Hi there. While you're embarking on this transformational journey, I'm sure that you've met resistance along the way, and I'm wondering if you can give us, a concrete example of how you've managed to shift that so that there is more collaboration and integration.
I think at one of our first sessions, I was new to the LHIN as a CEO, and we went to a session. And I was trying to start off my presentation. I didn't get, more than a few pages into it, and an individual stood up and read off a very long letter of everything, that was wrong in the healthcare system. It was largely about the provincial government. I was, newly from the provincial government, and I thought this session is not going to go well. But we proceeded and we presented all that we're doing. And, by the end of the session, people were saying, well, why didn't we know about this initiative? We have an initiative at Women's College with, with access to internal medicine. We have access to interprofessional teams at our CHCs. We have so many initiatives. So people actually said, well, we want to sign on for your meeting so we can, kind of access all these innovations that are starting to spread across the LHIN. So in our discussions, and we talked to hospitals, we talked to primary care, talked to our community providers, we really said, we're not in a place where we can force people to participate, but we have to offer people a reason to want to attend meetings and to participate. I think we've done that pretty successfully. We just issued a primary care bulletin of all the initiatives we've done to support primary care. And I think it's allowing our primary care leads to go out into their sub-region and say, these are things the LHIN is working with us on.
Hi, Susan.
Hi.
I'm Anne. I actually work with the Toronto Central LHIN, formerly the CCAC. And I just wanted to bring a couple of points all together.
Yeah.
Somebody asked what the difference was in 2006 to now, and somebody else was talking about involving community. One of the things I wanted to highlight is there's a real trend, I think, socially and in the city of Toronto to be community. There are a lot of new apps, there's a lot of social gatherings, there's a lot more community. I come from a really small town. My first week in Toronto, I knocked on the door of all my neighbors and introduced myself in the high-rise. It didn't go well. But I think that if I tried that now, I think I would get a much different response. I think there's a natural trend towards trying to build closer community and support each other in smaller sectors. And I think what's happening in the LHIN and the conversations that we're having, as somebody who is a frontline worker and somebody who's lived in the city a long time, I'm excited by what that, and that's one of the differences. One of the differences is we want to help each other. And not just from the higher levels and the planning part, but from the community, from the citizens who are actually living in those areas.
No, I think that's an excellent perspective. I talked about the LHIN's lens on the system changing, because it was one thing to meet regularly with the CCAC and get the report on their services, their funding, their challenges. It's quite a different thing when it's actually your role. So, we spend time weekly at our management team trying to understand all the metrics, the services, the populations, and I think that's just so helpful for the LHIN to actually understand at a quite detailed level who's in the system, who's getting the services, how the system's responding. And that is different. That is a big difference.
Hi, Susan. Brent McGough from Canada Health Infoway. Thank you very much for your presentation. It was excellent and great to sort of see your vision for Toronto Central LHIN. I'm wondering if you could talk a little bit about patient portals and how you see that playing into your vision. Infoway, with the support of the Ministry and eHealth Ontario, have done a project just recently in southwestern Ontario across the 4 LHINs to create a single portal, a doorway really for patients and families to connect with their health system and their information. I'm wondering what your thoughts are about that for Toronto Central and really for the broader GTA.
Well, it's interesting. I've been at about 2 briefings on that, and I think the Southwest, your CHI project is using the Sunnybrook portal. So I've been asking, how is the Sunnybrook portal going to be implemented across the Toronto Central LHIN? We do have a patient portal as one of our priorities in our local digital health plan. Not all our hospitals have a health portal, a health patient portal, but that would be our aim. And we're going to need to figure some standardization on that. And I think what you're offering in the Southwest, as I understand it, is that there'll be a common application where people can sign on, as opposed to, in this LHIN, people would have to go through the Sunnybrook instance. So that is a priority for us. We're very interested in the initiative.
As people are aware, we are out of time. Thank you very much, Susan Fitzpatrick.
Thank you.
Our next Breakfast with the Chiefs is October 18th with Dr. Michael Gardam, the chair of the Medical Advisory Committee for UHN, and he will be talking about the complex road to lasting change. Thank you very much and have a wonderful morning.